Hello people, I am Dr Muskaan and I am here to share a very interesting case with you who has led to many complications. So let's start. 44-year-old male has come to ER with the complaint of hematomasses. There was only one episode and he was known case of hepatitis B related CLD. Now, there was no complaints of abdominal distension, body swelling, altered sensorium or constipation. On arrival, vitals were normal. On examination, parallel was present. There was no hepatosplenomegaly, no shifting dullness. There was evidence of umbilical hernia in USG in the past reports which he has bring to ER. So on auscultation, there was decreased bilateral air entry in infra-axillary region. Bilateral creps was present in infraclavicular and memory region. On CNS examination, there was bilateral pupil which was sluggishly reactive to right. There was no hepatic flaps. Bilateral plantar flexion was present. Let me take you towards the investigation side. The blood picture was, it was anemic, thrombocytopenic and leukocytosis. Let me take you towards the KFT. Urea was 97.2 which was increased because normal is still 18 mg per dl. Creatinine was 2.4 mg per dl which was also increased because so normal is 1.3 mg per dl. Sodium was 150 millimole per liter, my dear friends. That means hypernatremia is there. Potassium was normal, that was 4.2. As you know that potassium normal values lies between 3.5 to 5.5 millimole per liter. Chlorine was 119.8 millimole per liter, which was also increased because normal value of fluorine lies between 86 to 108 millimole per liter. So in KFT we can see that there was electrolyte imbalance, that was hypernatremia and hyperchloremia, and you can also see that urea and creatinine was also increased. Further, LFT was deranged completely. There was hyperbilirubinemia, hypoalbuminemia and serum transaminitis because HDOT was also increased. Other tests which was done was dengue test, NS1 antigen, IgM, Ig test which was negative, typhoid IgM was positive, rapid malarial test was negative. My dear friends, PT-INR value was 31.2 to 2.31 which was increased. On ABG, pH was 7.16 which was leading to acidemia. PCO2 was 47 which was also increased. They both are in opposite directions, so metabolic and the pH is decreased to acid sources. Now lactic acid level was 6.6 which was giving us the sign that there is increase in lactic acid because normal is still 2 and it was taking us towards hagma. So from ABG picture we came to know this is metabolic acidosis with hagma. Further, ammonia was also increased, 124 microgram per dl. Normal is 27 to 102 microgram per dl when ammonia is increased. So let me explain you from the simple terms. In liver, when we take LFT and it is deranged, we see that from GIT protein breakdown occurs and from that ammonia is released. When ammonia is released, it goes towards the brain and it crosses the blood-brain barrier and it causes hepatic encephalopathy. In hepatic encephalopathy, ammonia is the main culprit, and in these reports ammonia level are raised. So this was encephalopathy grade 4. Grade 4 is totally comatose patient who does not respond to painful stimuli. Grade 1, 2, 3, 4 are there. Grade 4 does not respond to any stimuli. Grade 3 responds to painful stimuli. Grade 2 is has slurred speech, confused, disoriented, and grade 1 has decreased mentation. So the patient was not responding to painful stimuli, so it was grade 4, and the ammonia levels help us to make the diagnosis towards hepatic encephalopathy. Further, my dear friends, USG findings were there was impressions of mild ascites, mild splenomegaly with grade 1 fatty liver, umbilical hernia. We did the non-contrast CT brain in which there was no significant finding which was present. MRI brain was done in which there was left side maxillary fungal sinusitis. Now further, there was UGI bleed for which we have done the band ligation for the large esophageal varices, and it was grade 3 of that. There were 3 bands which was applied, and nipple sign was appreciated on esophagus. Further, the patient was, when it was a little bit on improving side, the patient was passing motion, there was melena present in the stools. So when it comes to management part, patient was on mechanical ventilation ACVC mode, FiO2 was 35, PEEP was given 6, and tidal volume was 475 ml. Patient conditions right now, he is in sepsis because vitals are deranged, vitals are not normal. Patient is comatose, BP is 95/51, pulse rate is 113 per minute, hypotension है, tachycardia है, which is showing us कि shock में जा रहा है patient. He was febrile, SpO2 was 98% on mechanical ventilation, and respiratory rate was 28 per minute. So till now, what all diagnoses we have made? We have made, he was known case of hepatitis B, and alcohol related liver cirrhosis. Second was UGI bleed, that was upper GI bleed. The third was grade 4 of hepatic encephalopathy by the ammonium reports. Fourth was sepsis, when we have seen the vitals of the patient. The urine output was also less, my dear friends. It was around 1380 ml, and it should be around 3000, because fluid was also given to the patient, and ascites was also there on the ultrasound. So till now we have 5 points in our diagnosis. One is hepatitis B and alcohol related liver cirrhosis, second is your UGI bleed, third is your HG grade 4, fourth is your sepsis, and fifth is your ascites. Now what was the treatment which was given to this patient? Vasopressin was given to increase the urine output and diastolic BP. Fluid which was initially given was half DNS at 120 ml per hour. Injection NORAD was given at 2 ml per hour. Patient का जो albumin था, that was low. I have told you that in the LFT report it was 2.2 gram per DL, and normal albumin level is 3.24 gram per DL. So we give albumin when there is hypoalbuminemia, एक indication होती है ये. So albumin today it has started at 20 ml per hour. Tazac was going on because there was increased TLC, but now instead of Tazac, anidulin injection is given. What was the indication of giving anidulin instead of Tazac was when the patient is not improving. When we are giving antibiotic, we should shift our management towards the antifungal treatment, which will help the patient to improve. So at last the diagnosis was hepatitis B, alcohol related decompensated CLD, UGI bleed grade 4, hepatic encephalopathy, sepsis, and ascites. So the take home message from this case was your Tazac anidulin concept, albumin कब देना है, sepsis में patient कब होता है, your HAGMA reports in ABG, metabolic acidosis with HAGMA. Further, ammonium level was increased, leading to hepatic encephalopathy. So that's all. I really enjoyed working on this case because there are many complications in this case, and that's all. So Dr. Muskaan is signing off now.